Working? Mayan, is it working?
Yes, you can start.
Right. Okay, shall we start? Good morning to Professor Jerome and Dr. Patricia, and good afternoon to the all the Myanmar colleagues from the revolution and participating and then leading in the revolution, or doctors and nurses participant. And today, our continuing medical education program will be from the our colleagues and then our friends from France, Professor Jerome Senet and Dr. Patricia Senet. And they are going to tell us about the ischemic chronic wound and ischemic limbs today topics. I would like to say thanks to the Professor Jerome Senet and Dr. Patricia Senet for the participating and also supporting to the our revolution. And we are fighting with the facet Myanmar military, and they are very aggressive and then brutal, and they kill many people, more than 3,000 people, and they burn our houses and villages, and then also even hospital and even monastery and churches, and then also mosque and then school, and they are very bad for the people, own people. They are killing own people, and your support will be a tremendous input for Myanmar and in this difficult time. And I would like to thanks to all of the supporter and then from the France. Professor Jerome, could you introduce Dr. Patricia, please?
Yes, thank you, Zo. Just to say that we continue to support you and to follow what's happened in Myanmar. So it's a great pleasure to introduce Patricia Senet. Patricia Senet is a dermatologist and also specialized in vascular medicine. She is working in Paris in Tenon Hospital, and she has a very big experience about chronic wounds. So I think it's very important for you to know how to manage, to know something about this chronic wound. It's a difficult management. So Patricia, thank you very much to participate to this program. It's very important for us and very important for Myanmar people. They need to improve their knowledge in medicine, and it's very important to give this topic. Thank you very much, Patricia, and you can share your screen now and start the topic. Thank you.
Hello to everyone. Thank you very much for inviting me, and good morning to everyone. So do you see my screen?
Yes, it's okay.
Yes, it's okay. Okay. Oh. So I'm a medical doctor, so I won't treat the surgical part of the management of ischemic wound, and we will see for the main ischemic chronic wounds what medical management can be proposed to the patients. So there are two kinds of ischemic chronic wounds: arterial leg ulcer or mixed leg ulcer, and diabetic foot ulcers. I don't speak about bed sore. That is another topic. Alors. So the epidemiology of leg ulcer have changed during the years before, and you see on this drawing that venous part of leg ulcer is decreasing since 10-20 years, and the part of the arterial ulcer here in this color you see are increasing because peripheral arterial disease is increasing in worldwide. So a lot of leg ulcers are now not more purely venous, but mixed venous and arterial, or purely arterial. You see some picture of patients with leg ulcer, typical leg ulcer that are well limited and several on the limb, and with exposure of tendon or bones that is a characteristic and not happening with venous ulcers. So the problematic of the diabetic foot ulcer is increasing everywhere in the world, because the prevalence of diabetes is 7% of the world population, and it is increasing particularly in young population. The prevalence of foot ulcers in diabetics is increasing as well, and is almost 6 to 7%. And it's a chronic disease because the risk of recurrence is high, very high, 40% at 1 year and 60% at 3 years. And the prevalence of amputation, mostly by infection or decompensation of arterial disease in diabetic foot, is high, around 5%. The presence of peripheral arterial disease in a diabetic foot ulcer is very important to detect, because it's the most important prognosis factor in the course of the diabetic ulcer, with a higher risk of amputation and higher risk of infection. The prevalence of peripheral arterial disease in diabetic patients is between 10 and 40%, depending on the age and the country, and is almost 1 patient out of 2 for patients with foot ulcer. You know that the other cause of diabetic foot ulcer is neuropathy that may coexist with peripheral arterial disease. So diabetic patient with peripheral arterial disease and foot ulcer has a very bad prognosis, with a risk of death of 50% at 5 years. The particularity of peripheral arterial disease in diabetic patient is that, compared to patients without diabetes but with peripheral arterial disease, in diabetics, the PID is higher and more frequent media calcinosis, that mean that revascularization gesture procedures will be much more difficult because of the highness of the wall of the arteries. And the other point is that the arterial disease is more distal and multifocal. That means that revascularization of the patient may be difficult or even impossible if it's too distal. So what is the prognosis of healing in these different ischemic chronic wounds? So we have some data about arterial and mixed leg ulcer. The natural history at 12 months, at 1 year, is amputation in 20% of the patient with PAD without possibility of revascularization, and in 50% of the case, complete healing. So it's not because arterial revascularization is not possible that everything is lost. And in 1 case out of 2, a patient may heal despite poor prognosis. And if you compare patients with leg ulcer of different causes, and you see in this study, it's more than 1,000 patients, and it depends of the cause of the leg ulcer. If it's a venous leg ulcer with ABPI, we will speak about ABPI, it's not IPS, but ABPI. You see that with compression, the healing is obtained in 6 months. In mixed leg ulcer, when you treat it medically with moderate compression and eventually by revascularization, if possible, you obtain a complete healing in about 2/3 of the patient. And in patient with arterial leg ulcer, when you proceed to revascularization, you obtain, like in the other study, complete healing in 1 case out of 2. And what happened in diabetic foot ulcer with peripheral arterial disease? There is a systematic review of all the study treating about this point, this topic, a recent review, you see, in 2020. And it was on more than 13,000 patients. And you see that the surgery is quite safe with a low perioperative mortality. And the limb salvage rate at 1 year is around 80%, despite whatever you use open surgery, bypass, or endovascular revascularization. And if you use only medical treatment, not this study, but in a precedent study or a precedent review, and it was one patient out of 2 that had limb salvage at 1 year. So it's quite the same for the prognosis that we see before. And the amputation at 2 years is around 10% after revascularization, whatever it is, endovascular or by open surgery. The other prognosis factor that decrease the risk of limb salvage and increase the risk of amputation and death is chronic kidney disease and infection. So what we see is that in this ischemic chronic wound, you have to assess the degree of ischemia to take care of this patient the best way you can. And because the degree of ischemia is the main prognosis factor, and depending of this ischemia, you can propose revascularization, endovascular or by surgery, and medical treatment. And obviously, all this treatment can be combined. So to assess the ischemia, you have several ways to do it. You can measure the ankle brachial pressure index, ABPI. It's the ankle pressure that you measure with a Doppler probe. I will see you on picture just after. And you divide this pressure by the humeral pressure that you take with a cuff like you are used to. So when the ABPI is higher than 0.8, it excludes ischemic origin in a trophic wound, But the problem is that this ABPI is not valuable, it's not a valuable tool in patients that have medial calcosis, and in particular, patients with chronic kidney disease, in particular when dialyzed, patients with diabetes, and elderly people. The other way to measure ischemia, and it's the best way to measure it, is to measure the two pressure. I will see you how to do, and the transcutaneous pressure in oxygen. I will show you also. So how you define critical ischemia? Critical ischemia is an important point. It means that you won't heal or you won't save the limb if there is no revascularization. So critical ischemia is defined in over the worldwide by the same points. It's decubitus pain or wound and ischemia measured by hemodynamic tool. So ankle pressure lower than 50 millimeter, or two pressure lower than 30, or TCPO2 lower than 20 millimeter. So the ankle pressure is not the best way to measure critical ischemia because, as I told you, in dialysis, diabetic and elderly patient, the measure must be falsely normal because of resistance to depression of the arteries. So the best measure is two pressure. So critical ischemia is defined in international conference by two pressure and TCPO2. So if how to measure ABPI, you see you have a probe, a Doppler probe, and a cuff, and you put the cuff on the ankle, you inflate the cuff, and so the signal of the Doppler of the probe decrease, and you don't hear it. So you inflate after the cuff, and you note at which pressure the signal is reappearing. So it's like when you measure humeral pressure, and you do the division of between ankle pressure and humeral pressure. The limitation, as I told you, is that BPI may be falsely normal if medical causes in dialysis patient, chronic kidney disease, diabetic patient. It's 1/3 of the patient with diabetes that who have normal ABPI, although they have PAD. So you see, it's not a good tool for this patient and elderly subject. The measurement of two pressure is here in this picture. It's the best tool is by laser Doppler. So the laser probe is put, you see, on the two, and the absolute value of the flux that indicates the laser Doppler probe is not valuable. The interest of the probe is to say there is arterial flow or not. So you inflate the cuff, and as you see there is no flow, and then you see at this pressure the arterial flow is reappearing. So you note that the pressure at the two is more than 100 centimeters of mercury. So it's normal. So the critical ischemia is defined by the pressure below 30, and there is a risk of wound. A wound can be considered as with a part of ischemia in the cause when the pressure is below 70. And as I told you, in case of critical ischemia, if the pressure is below 30, there is no healing that you can expect without revascularization or treatment by vasodilatators in case of any possibility of no possibility of revascularization. There is another system to measure the two pressure because laser Doppler is quite expensive, is a quite expensive equipment. So you have a less expensive equipment that is named SIS2. It's fully automated and based on the photoplethysmography technology like the precedent tool, but it's not laser, it's infrared in the sensor. And it's the same way you put the sensor on the two here, and you have a cuff here, and it's the system is inflating and deflating the cuff like the precedent tool automatically. and the pressure will be measured, and you will see on the screen here. So this system is a good one, less sensible than the precedent one, but much less expensive. It's about 1,000 euros, I think. So you can also measure transcutaneous pressure in oxygen. So it's made with probe, like you see here, that you can put on the foot, on the limb, and at different levels on the limb. And it's very useful in diabetic patients when you have necrosis or wound that you have to amputate, and to know at which level you can amputate the patient. And what we know is, I will say after, what we know is you have to, the TCPO2 higher than 20 to obtain the healing of the potential stump. So it's a very it's a very useful tool for diabetic patients when you have this kind of wound and you need to amputate, and you don't know if it's possible here or higher on the limb. So with this measure, you can measure and cut when the TCPO2 is higher than 20 or 30 millimeters. So it's automatic. It's quite longer than the precedent tool, but the advantage is that you can measure the oxygen intake into the skin at different levels, and you cannot do that with the preceding tool. The other problem, the problem with this measure of TCPO2 is that when a patient had edema or infection, there is when there is a sclerosis of the skin, you cannot measure TCPO2 with a good reliability, because the oxygen intake is falsely lower because of the stage of the skin, because of edema or because of sclerosis. So the values that you will obtain will be lower than the real value because of the edema. So it's one of the limitations of the use of TCPO2. So now we move to local wound care. So you have chronic ischemic wound, arterial or mixed leg ulcer, and diabetic foot ulcer. You know that the prognosis factor is the presence of peripheral arterial disease, and mostly the ischemia, and not the anatomic lesion, but the ischemia and the hemodynamic ischemia that you can measure to give a prognosis of healing. The other point to be considered is the presence or not of an infection. So for the medical management, that even whatever you revascularize or not the limb, you have to deal with local wound management. Obviously, the local wound care is an adjuvant treatment. It's not, there is no dressing that can heal faster a wound. The goal of the local wound care is to have a wound that stay clean, without infection, and without pain as well. But the etiologic treatment is the main treatment to promote wound healing. The other point is that you have to manage all the patients, and I won't abort this topic today because it's too long, but you have to manage cardiovascular risk factors and promote exercise and use a drug that show that have shown in several studies that they are decreasing the major adverse cardiovascular event. So it's when a PID is present, is to use statin, angiotensin converting enzyme inhibitors, and platelet antiaggregants. So I won't deal with that point today, but it's important to keep in mind that the patient has to be treated in his all aspect. So we go back to the local wound care, and the first thing is how to clean the wound. And in several studies and in the recommendation about chronic wound in all the world, all the country, is to use water and soap. And it's the best way to clean the wound and to avoid secondary effect, adverse effect that you may observe with antiseptic, for example. Why do you have to avoid antiseptic? Is because antiseptic, when they are used in a long term, there is a risk of allergy, a great risk, high risk of allergy, and the antiseptics in live can decrease the rate of healing because they are cytotoxic, especially povidone and peroxide. So if you have to use it, it have to be a short use, for example, 1 week or 10 days, and it's enough. The best way to clean the wound, you know that, it's to use pressurized irrigation to clean to try to remove the fibrinous part of the wound and the germs and necrotic tissue. So what dressing to choose? So what we know now, and this is also international recommendation, is that the choice of the dressing is not dependent of the etiology of the wound. So what we say today, it's the same for all the wound, all the chronic wound, despite the etiology. So it's valuable for venous leg ulcer, arterial leg ulcer, diabetic foot ulcer, and so on. So it's depending on the wound stage, if it's necrotic, fibrinous, or granulating or wound, and the amount of exudate. It depends of the localization and the size of the wound and the stage of the perilesional skin. How is a perilesional skin, for example, eczematous or macerated. And it depends as well of complication, and we will see that you can use some kind of dressing in case of hemorrhagic wound or in case of infected wound. So the place of dressing, as I told you, in management strategy is an adjuvant treatment because the level of evidence is usually low for medical device such as dressing, and there is only few randomized control trial, except recently for diabetic foot ulcer and dressing from Urgo with booster of healing that inhibits protease. So you have always to associate the dressing with the etiological treatment, as we say. So when it's a dry necrosis, the first question to have is to ask, is there a possibility to revascularize the patient? So if yes, you can use after or before revascularization debridement. Sorry, this word is French, but the real word is debridement in English. And for that, you can use hydrogel that are dressing that contain 80% of water that will be released in the wound and facilitate the sharp debridement by the medical doctor or the nurse. So this kind of dressing are changed every 2 days to allow the water to be released in the wound, and that will remove the necrotic scar. So if there is no possibility of revascularization, the strategy will be totally different, and the deal here is to mummify, as you see here, the necrotic wound. And for that, you use dry dressing. It's not to humidify, but to drying the necrotic wound. So for that, you can use antiseptic, and we use a lot, very often povidone iodine, and because the problem is not to heal, but is to dry. And you can use gauze or alginate. You have in both cases to do a close monitoring of the risk of infection, because the risk of infection in dry necrosis in necrotic wound is very high. When you have exudative or fibrinous wound, like you see here with a lot of fibrinous tissue in the wound bed, the problem is whatever the wound is colonized by germs. You use sharp debridement to remove the fibrinous tissue and the biofilm, and dressing for debridement. Sorry, the term is debridement, and absorption of the exudate. For that, you can use alginates. That you see the trademark here, and you can use hydrofibers or foam dressing and you see here the trade name, but I don't know if you have that in your country. And you can use also sequential silver dressing, but whatever you have, you can use this three kind of dressing. And for example, there is no difference between the alginates or hydrofiber or silver dressing between them in terms of healing. When the wound is nearly closed, you can use, I like to say, whatever you want, because it will close really easily. So we use at this time foam dressing, interface, or other dressing. The problem to use petroleum plus gauze is that the gauze will be stick on the wound, and it can be painful when you remove it. And the advantage of this dressing, foam dressing, interface, or alginate or hydrofiber, that you can let the dressing 2 to 4 days on the wound, so you don't have to make the dressing daily, and it's economy in terms of nursing. So you can have specific situation recurring special dressing. For example, bleeding wound. Here you see it's a tumoral wound. It's not an ischemic wound, it's a tumoral wound, and here as well. But it's very often, this kind of wound are very often bleeding. So you can use alginate, because alginate have hemostatic properties. When you have hypercoagulous wound, for example, on this stump, you can use topical steroid to decrease the hypergranulomatous tissue, and to allow the epidermization. You have to down-regulate the granulation phenomenon to allow the epidermization. So we use topical steroids, and we put on the topical steroid a dressing, whatever the dressings that you want, for example, wound foam dressing. And when you have altered peripheral wound, like here where there is macerating and eczema, you can use interface because it's quite neutral and because it's quite easy to use on big area, on wound with big area. When there is melee wound, for example, here it's another tumoral wound, you can use a charcoal dressing to decrease the smell. So to resume, you have two strategies. Mummification in case of distal wound without possibility of revascularization, and you can dry the wound by dry dressing, for example, gauze, simple gauze, and by antiseptic. And then you can consider amputation when the necrosis is very well limited. If not, you can consider iloprost. Iloprost is a vasodilating drug that is used intravenous. When there is the objective of healing the wound, so you can use most wound healing that you obtain by occlusive or semi-occlusive absorbent dressing, like I told you, alginates, foam dressing, interface, and so on. And you use debridement, sharp debridement at wound bed, and autolytic debridement by dressing, or eventually you can use surgery for debridement. You can use also compression in case of edema and graft. I will show you how to use graft at the bedside. So autologous skin graft, you know that you can use mesh graft but it's you need a surgeon and a surgery theater, or pinch graft that you can do at bedside. The indication of autologous skin grafts are stump, particularly transmetatarsal stump, to boost the healing and to promote the wound healing, to shorten the healing time, and arterial ulcer after revascularization. And you can use as well graft for surgical wound when you remove, for example, a tumor or something on the limb. You can use skin graft to promote wound healing and to shorten the healing process. But there is few studies of that. So you take a little part of the skin on the thigh, for example, and you put so it's you remove a piece of skin that are very thin to the superficial derma, and you put the graft on the wound, and you close the wound with a dressing, and you open the dressing only 4 to 5 days after. And as you see here, it's an arterial wound after revascularization, and it's 1 month after, and you see here the pinch graft, the scar of the pinch graft. You can use as well topical negative pressure on chronic wound. There is only few studies really with good value of topical negative pressure on chronic wounds. And finally, the interest to use this technique is to do it before grafting, to prepare the wound bed and to obtain a granulate a tissue that is well vascularized and without fibrin, and you can use that tissue to improve the graft, and the graft is more valuable and will take will be better integrate if there is a wound bed that has been prepared by topical negative pressure. So, for example, here you see the system of negative pressure with a foam and negative pressure that collapse the foam on the wound and there is a system for the exudate, and you see that you can obtain here, it's in several weeks, a good wound bed with granulated tissue, and after the graft, you see it is the graft is a success on this wound bed, but it won't be a success if we have this kind of fibrinous wound. So you can use as well on stump, like here in transmetatarsal stump, and it increases the vascularization, the oxygenation of the wound bed to prepare the wound bed to graft or to closing. The other point is that you have to treat the edema to increase the cutaneous, the skin perfusion in oxygen. And for that, you can use on mixed ulcer or on stump or on diabetic foot ulcer, bands that are poorly elastic or inelastic to avoid the compression when the patient is resting and to avoid necrosis. So with this kind of band, you don't have to fear necrosis because it's very well tolerated, and the patient, there is no pressure when the patient is lying, there is pressure only when the patient is walking. So we use this kind of bands in our country. I don't know which one you can have, but it's ones that are a bandage that is very poorly elastic. So that is for leg ulcer or stump when there is edema. But another point for diabetic foot ulcer, you know, that is the offloading technique. So you have several techniques here with a cast here or with special shoe, but I won't speak about that because it's a big topic. And the better way to offload diabetic foot ulcer is to use a cast that is done on the foot of the patient. You see here with a window, open window to perform the dressing even when the cast is in place. What about the infection? That is, you know, a bad factor of prognosis for healing or for limb salvage. So it may be difficult to diagnose in case of leg ulcer the infection, because there is you need to confirm an infection to have several clinical characteristics: unusual pain on or around the wound, sudden cessation of the healing process, increased size or increased exudate or increased necrosis or permanent discharge of the leg ulcer, and obviously general signs of sepsis. But you see, if there is edema, for example, that is not controlled, you can have a stop of the healing process, and you can have increased exudate. So you have to be prudent before saying that there is an infection and not a colonization or another cause of that may stop the healing process. The bacteriological sample on the surface of the wound is not very useful because you will obtain several germs, and these germs are the germs that are on the surface of the wound and not inside the skin. So it's not a good reflect of what is happening in the invasive infection. But you have to use bacterial sample if it's possible when there is a deep suppuration or abscess, and then you can obtain or identify the germ that is present in the deep part of the wound. If you have no germ, you have to target Streptococcus beta hemolytic A in first. That is the germ, the most responsible of infection for leg ulcer. So there is several recommendations to treat leg ulcer infection. Here are the English ones, the NICE guideline, and you see that the third choice for them is flucloxacillin. So it's penicillin with specificity for streptococcus and staphylococcus. And you can use in case of allergy, or if flucloxacillin is not suitable, you can use macrolides. You can use as well cotrimoxazole or penicillin and acid clavulanate. So here you have the recommendation in France. So this precedent one here was the English one. Here you have the French one. It's quite different, but it's not a recommendation for leg ulcer infection, contrary to the English one. It's a recommendation for cellulitis of the limb, whatever is the source of entry of the infection, but is often a chronic one. So you can use amoxicillin, so penicillin, in first choice with a good dosage that was shown to be useful in this case, in this kind of infection. If you are lower than this dosage, it may be non-efficient. So you use amoxicillin 50 milligrams per kilo by day in 3 doses with a maximum of 6 grams by day. In case of allergy, you can use macrolides, and we have pristinamycin that is with a very small spectral for the germ, only for coccigram plus germs, so coccigram positive germs. So it's very, I don't remember the word in English, sorry. So it's very useful for this. It was shown to be a good alternative in case of allergy. But if you have not pristinamycin, you can use as well clindamycin or other macrolides. The second choice is amoxicillin and clavulanate, or clavulanic acid. And if necrosis, you have to consider antibiotics with a wider spectrum, like beta-lactaminase 2, ticarcillin clavulanate, piperacillin tazobactam, and clindamycin that has toxin, antitoxin activity. For the diabetic foot ulcer, the diagnostic of infection is quite documented in the last international wound group diabetic foot ulcer guidelines that is available online and is free, and you can consult it. And you see that it depends on erythema that is around the wound. And the classification of the infection is unaffected, infected, mild infection, moderate infection if the erythema is extending more than 2 centimeters around the wound, and severe infection is mostly defined by a systemic sign of sepsis. So you see here the recommendation of this international group for diabetic foot infection. So for mild infection, it means erythema lower than 2 centimeters around the wound. You target gram plus cocci germs. In first, you can use penicillin or clindamycin if allergy or macrolide. And if there is a high risk of staphylococcus, you can use as well antibiotics that target staphylococcus like macrolide and linezolid, or trimethoprim sulfamethoxazole. In case of moderate to severe infection, it means that it's higher than 2 centimeters around the wall. you can use as well. You can extend the antibiotics to target as well gram-negative germs and use what is on this slide. You can consult everything on this web address, and there is everything about the management of diabetic foot ulcer infection, offloading, and so on. Is surgery necessary when there is a diabetic foot ulcer with suspicion of bone infection, when you can feel the bone with a probe when you explore the wound? It means that you have a contact bone infection. So this, we have not a lot of study about that, but this study was very, very interesting. Despite it's quite 10 years, it was performed 10 years ago. So it's not a lot of patients, but you see that it was compare antibiotics during 6 weeks versus antibiotic 10 days and conservative surgery limited to infected bone. So the bone was removed, the infected bone was removed at the bedside. And you see that finally, patient healed in 18 patients in one group and 80 patients, nearly the same in the other group. So if it's not possible to have surgery, if you cannot debride by the infected wound and the bone by surgery, you can use antibiotics, but longer, 6 weeks. Or two months, it depends. 6 to 12 weeks, sorry, 6 to 12 weeks, and obtain quite the same result. But it's a limited study, as you know, with with only few patients. So the take-home messages are for ischemic wound are that you have to treat the risk factors and the cardiovascular risk factors that are associated with this kind of wound, and to perform the causal treatment that is revascularization, control the glycemia, and so on. For distal wound necrotic, you can use dry dressing. For wound in direct healing, you can use mechanical debridement, graft to accelerate when granulating wound, and dressing that use moist to promote healing. And you have to fight against edema, pain. I don't detail this topic, but it's obviously very important, and control infection eventually by antibiotics and local surgery for debridement. Thank you.